Hi, Dr. Dave Jurman here with my colleague Dr. Andrew Pacinelli and our patient Jack. Jack has returned. It's 4 months since his initial surgery where we did a end sequence full arch reconstruction with immediate load. We saw Jack back twice since the surgery, and now it's 4 months since that date. And I'm going to lead it off with my friend Dr. Pacinelli.
So Jack, this is the first time I'm seeing you, so why don't you tell me how this experience has been for you, how you're functioning with your existing prosthesis?
Well, the teeth so far is great. I have had no problem with them, except for sometimes with soft food they get stuck a little, like on the inside of my mouth. But as far as pain and eating anything, I'm able to eat anything I want.
All right, great. All right, so when Jack takes his mask off, this will be the first time I see him since I did a little occlusal adjustment at the post-op visit. So I just want to make sure that his prosthesis is intact, it's not loose, and then I'm also going to evaluate the soft tissue relative to the intaglio or the flange area of the prosthesis. So we're going to show you after we can retract his lips what we're looking for, and then I'll take it to the next step of how we're going to relay the information that we captured at the day of the surgery with the clear duplicate prosthesis to the laboratory, so the next visit Jack will be able to get his definitive prosthesis. All right, so retracted view of Jack in MIP or an occlusion. His occlusion obviously is comfortable, the prosthesis is intact, and what I'm looking at is the prosthesis relative to the gingival tissue, and it actually looks really nice. So that goes along with all of the surgical planning and all of the guides and the soft tissue guides that help this work out the way it is. So right now, what we're going to do is I'm going to remove this temporary prosthesis, and we're going to insert the clear duplicate prosthesis. I need to replicate the occlusal position that Jack is comfortable with now in this prosthesis with the duplicate prosthesis. So that's going to be the next step, and we'll show you how we do that. Okay. So Jack, the way it feels right now with your bite, I want it to feel very similar when I put the other one in, okay?
Okay.
So just keep that in your mind, okay? I'm just picking out the screw hole access material. I use PTFE or Teflon tape along with resin material called Clip by Voco. Some of that washes out, but it's okay because now we have the nicely sized Teflon tape that comes out fairly easily. Some people like to use cotton. I'm not a huge fan because that harbors a lot of bacteria and it's hard to pick out and it can deteriorate. Sometimes clinicians will use a PVS, a light body PVS material, and just squirt it in the access hole, which is nice to take it out. I'm not a huge fan of that because usually it has a shade to it or a color to it, and it'll be some patients might complain about the aesthetics of that. So the key is utilizing the PTFE, the Teflon, in a way where you almost want to pack it, and where it terminates is almost maybe 2 millimeters from the occlusal access. So you're not digging down in there, and you want to have it in one piece. You don't want to have multiple pieces that you have to keep pulling out, because then you don't know when to stop. If you have one piece, you should cut it just short of the access hole, so you only have a little bit of the occlusal material to remove. And now all the screw holes are clear. The case is planned for 6 implants. However, at the time that we picked up the provisional, one of the implants has a little slight mobility. That was in sight. You want to call it 6. Because it didn't have good primary stability, we just bypassed that implant. We took it out. But it's fine. Obviously, his prosthesis is intact, no discomfort. So again, when I remove a prosthesis, I like to loosen it from the most posterior implants. So when I remove it from the anterior, it just falls out easier. And there's prosthesis. He's got a little debris, which is not uncommon. Okay. And what you'll notice is that we added the bisacral material around some of the posterior implants, and they served as occlusal stops. And we don't have that on the clear dupe. So this is kind of where we have to kind of use some of our traditional dental techniques to ensure that we have an appropriate occlusal position and a foundation for the definitive prosthesis to be built. So what I'm going to do is I'm going to put in the clear dupe prosthesis. And if you recall, at the time of surgery, we allowed for some space in the intaglio between the prosthesis and the tissue, because we have to capture the soft tissue. So what we're using this clear duplicate for is confirming, one, the aesthetic position to coincide with the existing provisional, which Jack likes and I think is acceptable. We are achieving the occlusal position, and we're also achieving an impression. We're impressing the soft tissue because we've already impressed the implants with the multi-unit temporary cylinders, but we have to capture the soft tissue because the prosthesis needs to be made to the soft tissue. So it's tight enough to the tissue where he's not collecting food and debris and harboring bacteria, but it's also allows for him to be able to clean it as well.
Dr. Pacinelli pointed out that around the multi-unit abutments, there's nice keratinized tissue around them. So during the surgery, I made sure not to remove too much tissue, especially the keratinized tissue. So when we get to this phase, the multi-units, they look good, and there's good connective tissue around them. During the surgery phase, with the end sequence protocol, all the abutments are pre-planned. But sometimes during the healing phase, especially during the restorative part, Dr. Pacinelli might decide to change a multi-unit. And I'm going to ask him, when is a good time to change that multi-unit, and what does he look for?
So right now is the time to change the multi-unit. But you have to make sure that if you change the multi-unit for the definitive prosthesis, you have to now go back and modify your clear dupe or start from scratch with like a traditional implant impression. However, the reason why you would swap a multi-unit abutment or bypass a multi-unit abutment and potentially go to the implant level would have to do with soft tissue healing. So like Dr. Jurman was stating, the multi-units are planned ahead of time. And there's different heights of the multi-unit abutments and there's different angulations. Now the angulation is going to be consistent because if the angulation is off, meaning where the screw hole axis of the prosthesis is going to emerge, you're going to pick that up at the time of surgery, unless your provisional is really not in the appropriate position. But if your provisional is in the right position, the angle of the multi-units are going to be accurate. But the multi-units are made in different tissue height. And sometimes when the patient heals, they have some tissue bounce back. And now the multi-unit platform sits superior to the tissue, and which could lead to a void or a gap underneath the prosthesis. And in those instances, I would swap out the multi-unit abutment. I would swap, if the platform was superior to the tissue, I would swap it for a shorter multi-unit abutment. And sometimes, if the shortest multi-unit abutment, which is I believe 1.5 millimeters, is still sitting too far above the tissue, I will go right to the implant level. Make sense? So I will bypass a multi-unit. I do use the changing a car tire technique. You get it until you feel a little resistance, you don't torque it down, and then you go opposite, as if you were changing a car tire. And then at the end, you would then give a nice little final tweak down, so make sure it's fully seated. just hand tighten.
And after you get the clear dupe in, do you start making adjustments to even the teeth itself here?
Exactly. I'm gonna, right now that this is in, what I'm looking for is, first, we can look, everybody loves the aesthetics, so we can look for aesthetics to make sure that the teeth are in their appropriate position. We can check the occlusion, and then we'll look at the space between the tissue and the prosthesis. He does have an even distribution of his occlusion, which is good. I'm still going to capture a bite registration, an occlusal registration. What I'm looking at now is our midline on, is our buccolingual position where we would like it to be, is our smile line where we want it to be. Now when I look at Jack, I feel as though tooth number 11 is too incisal, or it's too long from an aesthetic point of view. So I would just, and I will do it in a second with a handpiece, I'm just gonna nick that cusp. And for the most part, I think we're really in a good spot. It doesn't always line up like this, but we're in a really nice spot. The thing is that I have to capture the soft tissue here. There is not enough of a gap for me to capture the soft tissue. So what I have to do now is I have to relieve the intaglio of the clear dupe so I can inject light body polyvinyl siloxane. Okay? I'm going to open them up everywhere. Okay? So I can inject impression material. Jack has a lot of really robust keratinized tissue. Some people that have a more thin phenotype of the tissue, you'll see a lot more discrepancy in the soft tissue after surgery. I don't know if you find that as well from the surgical perspective. This is how you can modify this clear dupe if you ever wanted to make any changes. I mean, it looks a little too much like Dracula, so I don't like super prominent canines, but little things that you can do with this, because this is the guide. And if you really are particular about what you would like, what you could do is utilize the clear dupe as a reference. Capture all of the records we're capturing today: occlusion, soft tissue, tooth position, and then you could ask for a wax tooth setup to try it in for the patient beforehand, so you can confirm it with the tooth position and the shade and the occlusion if you would like. It's an additional step. It's obviously an additional fee, but some people who are really particular, that's what they would like to do. So right now, I relieved, made a little more space. Close down for me. Underneath, on the tissue side of the prosthesis, I'm going to capture the occlusal record right now, and then I will capture the soft tissue. I don't need a ton of occlusal registration material here, just enough to capture the tips and of the cusp. Because the patient, over the past few months, there might have been migration of some dentition. You never know. It's always good to have a new scan of the opposing at this visit, or making a new impression, whether it's an alginate or alginate alternative. So while he's occluding, you know, might as well just get this going, because it doesn't really take that much. I'm gonna capture the soft tissue. Just stay close to me. I'm just drying. You apply adhesive to the intaglio or the tissue surface side of the prosthesis. And what we're going to do is just inject light body polyvinyl siloxane or polyether or whatever material the clinician likes to capture our soft tissue. All right, Jack, open for me. Open big. Good. Bite down for me. Beautiful. And we want to make sure it's full. So you capture more than you need on the soft tissue. So we're not going to create an overhang or a ledge. Just stay close.
One of the things that patients always ask me before they go back to Dr. Pacinelli, especially patients who have some dental anxiety, is that, am I gonna need a Novocaine injection? Is this gonna hurt? Am I gonna be swollen? Am I gonna miss work? And you can see that Jack is in no discomfort whatsoever, and there's no Novocaine, no lidocaine. So.
Right, and so it all goes with the planning. The appropriate multi-unit abutments were selected. They're right at the gingiva, which is really nice. So you're not traumatizing the tissue when you are putting in the provisional or putting in the definitive. Yeah, the reason why you're not getting the pain is because oftentimes, if you're doing the traditional method, the patient would come to me, whether they be wearing a denture,
Right, that doesn't work.
or if you're converting it at the implant level, where you're not using the abutment, which we have now is the abutment level. Sometimes that tissue collar, and especially for a patient like Jack, where he's got that really thick phenotype of gingiva, it would be very uncomfortable to be placing either a impression coping with very thick cuff of tissue, or if at the time of impressioning, you're going to deliver the multi-unit abutment at that moment. So delivering the multi-unit abutment at the time of surgery affords these advantages. But the only drawback again is that if you get some soft tissue rebound, sometimes the platform of that multi-unit sits too superior to the tissue and you have to swap that out. But again, if you're swapping out a multi-unit around on an implant and you're shortening the collar, the chances that the patient's going to have discomfort is very minimal. Make the occlusal record with this elastomeric material. You can make the occlusal record with a rigid material like acrylic or a bisacryl, whatever you feel comfortable with. You can make it with an aluwax, traditional denture materials. The key for this is the occlusion. So if you're concerned that the laboratory is not going to mount your case the appropriate way, what I would do is either mount the case myself, or I would articulate the new lower cast against the upper duplicate, and I would hot glue gun it together and send it to the lab like that, just to be sure. But again, there are different ways to do it. For me, I don't like to leave anything to chance. Before we leave, we'll talk to Jack about if there's anything that he doesn't like aesthetically about his existing provisional. He mentioned that he might want to see a shade a little lighter than what he has, and that's very easy. Just changing the shade, bringing it up a little bit in value, it'll be no big deal. So again, I like to remove the screws posterior to anterior because it's easier to remove the prosthesis for me when I go posterior to anterior. So I'm not fumbling with a loose prosthesis trying to take out that most distal implant. If you notice, there are maybe two little voids here where I was deficient in my impression material capturing the tissue. It's not that big of a deal because the technician can just drop a little wax, or you can even drop a little impression material in that just to fill the void and kind of go with the contour of the tissue. But that's perfect. It's enough information for what the lab needs. I mean, it's more than enough information. So what we're going to do now is we're going to put back, you want to clean up?
Yeah.
We're going to put back Jack's prosthesis and let him go home. The reason why I also like to do this work is because if you plan it appropriately, like this was, these visits are not that long because you've done all of the work ahead of time.
Yeah.
And so I would normally allot for this appointment maybe about an hour. If you really want to, be sure, an hour and a half would be plenty. But if you think about what we're achieving here in the visit after the implants have integrated as deemed by the surgeon, we are confirming our implant placement and the abutments. So it's a confirmation, the clear dupe is a confirmation jig. It's an occlusal record. It's an aesthetic verification, and it's a soft tissue impression, all in one visit, and you're doing it in an hour and a half to an hour and a half. So it's super efficient. The screw is from the temporary.
Right.
The cylinder.
Exactly.
Gotcha.
Now they'll pour it.
All right.
Jack, until we meet again, my man.
All right. Thank you. Thank you.
I'm gonna have to do it.
Pleasure.